Hey, I think it's a good time to start. Good afternoon, everyone. Welcome to our webinar today on the topic of anxiety in older adults, presented by the Canadian Coalition for Seniors and Mental Health. My name is Titus Chan. I'm a project coordinator at the CCSMH, and I have the pleasure of being your moderator for today's event. It's a really exciting time for us at the CCSMH. We have over 3 guidelines launching this spring, so we're very, very pleased to have you all joining us for this webinar. So we can move to the next slide. So before we dive into today's presentation, I just want to go over a few housekeeping notes. So the first is that this webinar will be recorded. So in about a week, we're aiming to have the webinar uploaded onto our website. So we'll be sending out an email to participants about that. And throughout this webinar, we will be sharing some resources in the chat. So just a reminder to keep an eye out on that for some of the links that we'll be sharing to some of the resources and some of the other CCSMH things that we developed over the past winter. And of course, if you have any, if you require any assistance with the Zoom platform and have any questions, you do feel free to message our team member. We have Peter Snow available here to assist. So definitely feel free to reach out if you have any questions. We do have a Q&A portion that will be happening after our presentation. So throughout the presentation for Dr. Iaboni, we do recommend you to submit any questions that you have that might come up. Definitely feel free to voice any of those questions, and we'll try to get to them throughout the Q&A section. And then after our presentation, we do have a quick survey. It's a very short survey that's definitely really important to capture the work that CCSMH does. So we definitely encourage folks to complete that survey prior to our Q&A discussion. And so next slide. And so now, before we start, I'd just like to introduce our Executive Director, Claire Checkland, who will be sharing a few opening words and a bit more about the work of CCSMH in supporting older adult mental health across Canada.
Hi, everyone. Thanks so much for coming today. We're very excited to have you. As Titus mentioned, my name is Claire Checkland. I'm the Executive Director here at the Canadian Coalition for Seniors Mental Health. We're so excited to present to you today the new Canadian guidelines for the assessment and treatment of anxiety in older adults. I do try to treat all of our projects with equal enthusiasm and excitement, but I will admit that this one is especially close to my heart. Anxiety and anxiety disorders are things that have affected me personally and that I can absolutely relate to. I couldn't be more proud that we have now developed these guidelines that give practical and evidence-based guidance on the prevention, diagnosis, and management of anxiety in older adults. I want to thank, in particular, Andrea.
Oh no, it looks like we might be having some issues with the internet here. Okay, we'll just wait a little bit here and see if Claire comes back. Okay, it looks like we might have to move on to the next portion here. But yes, hopefully we'll hear from Claire at the end there. So now I'd like to introduce our presenter for today. We have Dr. Iaboni joining us. Dr. Iaboni is a geriatric psychiatrist at the Toronto Rehabilitation Institute and an associate professor in the Department of Psychiatry at the University of Toronto. So Dr. Iaboni has been at the forefront of a lot of older adult research in Canada and is the co-lead of our recently launched anxiety guidelines.
Thank you so much, Titus. I'm really pleased to be here today on behalf of the whole Anxiety Disorders Working Group to present our work on these guidelines for assessment and treatment of anxiety in older adults. So my goal today is to use this time that we have to provide you with an overview of some of the key recommendations for the assessment and treatment of anxiety, and also to illustrate some of the recommendations with some case examples to help you understand how they might apply in practice. So we're not going to go through every single recommendation. If you're interested in the full details, I would encourage that you go to our website and download the guidelines. But hopefully you will get the Coles notes today, the important bits. The slides are a bit slow to change over. Let's try this. There we go. So I don't have any financial interests to disclose. I don't receive any money from pharmaceutical companies, for example. I did get an honorarium from the CCSMH to help support my work on this project. And the project itself was funded with contributions from the Public Health Agency of Canada. And the full conflict of interest information for our working group is available on our website. So to start off with, I want to make sure we're on the same page when talking about what is anxiety. Anxiety is a normal physiological response to stress or threat, and it's there to motivate us to take appropriate action when needed to keep ourselves safe. I want to give you an example. It would be normal to feel some anxiety if you look down and saw the brake warning light turn on your dashboard. And that anxiety is helpful if it motivates you to find time in your busy schedule to get the car to the mechanic to get it checked out. But if your anxiety leads you to start ruminating about, about catastrophic car accidents or Googling brake failure or not being able to sleep, now the anxiety is becoming excessive and unhelpful. And an example where this might move into the domain of an anxiety disorder would be if someone developed a driving phobia, where you might experience anxiety when in the car and then decide that you needed to avoid or give up driving. So, where anxiety is unhelpful is when anxiety persists after the threat has passed or when it's out of proportion to the magnitude of the threat or the danger. And anxiety goes off the rails in a very typical way. Usually it starts with an activation of our sympathetic nervous system, or activation of our fight or flight response, which creates some uncomfortable feelings that are hard to ignore. And our brain has the signal that something isn't right. And then we start to develop sometimes something called catastrophic thinking, where we overestimate the potential threats, seeing danger where there isn't any, and we start underestimating our abilities to cope with the situation. The last step to anxiety going off the rails usually involves avoidance or safety behaviors. Our instincts tell us that we need to get away or stop doing something, and we feel immediate relief from anxiety when we avoid. But in reality, this only reinforces or entrenches the anxiety by taking away from us the opportunity to learn that the situation is not so dangerous and that we actually can cope. And in those scenarios, anxiety moves from something that's helpful to something that's unhelpful and that can cause a lot of distress and impairment. To illustrate this, I want to tell you about Mr. Christie. He's a healthy 73-year-old man, quite proud of the fact that he's not on any medications until recently when he was diagnosed with hypertension. He decides he's going to be proactive about this and buys a blood pressure cuff and starts recording his blood pressure multiple times a day. One morning, he wakes up and he doesn't feel that great. He's got a bit of tightness in his chest and some shortness of breath and feels a bit jumpy. And he decides to check his blood pressure lying down in bed and finds that it's the highest it's ever been, 175/95. And he starts to worry that his blood pressure might be going up while he sleeps and lies down. And so he starts taking the measurements repeatedly while lying down. And unsurprisingly, they're all a bit high. And he starts getting more anxious and he feels tightening in his chest and difficulty breathing, particularly when he lies down. And he attributes this to his blood pressure. And he starts sleeping every night in an easy chair next to his bed to avoid lying down. So this avoidance behavior fortunately comes to light at his next primary care visit with his nurse practitioner. And the nurse practitioner assesses him and he knows he's a relatively healthy guy and can't find anything wrong with him that would explain what he's describing, but goes through the story with him and really starts to see what's going on and provides him with some education about anxiety and its physical symptoms and its effect on blood pressure. And they sit down and they review the anxiety cycle together and how his worried thoughts about his blood pressure while lying down led to some anxious feelings. And then he got some temporary relief from this anxiety by not lying down, but it seemed like the safest thing to do at the time, but it hasn't helped his anxiety. It's actually getting worse, and it's leaving him very tired and sore. So they come up with a gradual exposure plan. He comes into the office every few days, and he lies on the examination bed with the bed at a gradual reduction in the angle of the head. And when he first lies back, his anxiety spikes, but it slowly comes down over the next 10 minutes. And he's actually able to lie quite comfortably there for a further 10 minutes without any anxiety. And after 4 visits, he can now lie flat with very little anxiety, and he's actually able to return to sleeping in his bed. And he reaches an agreement with his nurse practitioner that he'll only check his blood pressure once a week while he is sitting. So I wanted to spend a bit of time in setting this groundwork for 2 reasons. First, if as healthcare providers, we understand how anxiety works, how it goes off the rails, and how we can talk about anxiety with our patients, that in and of itself can have a really important impact. And second, because these guidelines are a bit different than other CCSMH guidelines, in that we're not just focusing on anxiety disorders, and that's the sort of 6% of older adults who would be diagnosed with a full anxiety disorder. But we're recognized that there's a lot of older adults who fall in this middle ground, maybe about 10 or 20% of older adults, where they have clinically significant anxiety that causes some distress or disability, but not an anxiety disorder. And so by having a broader approach, we can actually help people manage anxiety in general and prevent the development of anxiety disorders. So anxiety is the most common mental health challenge across the lifespan. So why are we doing guidelines for older adults specifically? Anxiety in older adults does look different than it does in other life stages. Some older adults may have trouble recognizing or naming the symptoms of anxiety, or are more likely to attribute those symptoms to medical issues. Older adults can also experience changes and transitions at this time of life that can create new feelings of vulnerability or get in the way of their usual coping strategies. Older adults can also they have change in their roles. They're not necessarily going to work every day. And that means that avoidance behaviors due to anxiety can sometimes be easy to miss. Like if an older adult gives up driving, like in that example I gave you earlier with the brake light, it might not be recognized as a driving phobia, but it could be seen or assumed to be just an age-related transition. And there is a fair bit of ageism out there, which can result in anxiety being discounted as normal or expected. That what do you expect? This comes with getting older, but it doesn't come with getting older. And ageism can also get in the way of offering effective treatments. We know that some psychotherapies are very effective for anxiety, but there's, I think, a belief out there that older adults won't benefit in the same way as younger adults from psychotherapy. And then the last reason that's really important is that we have to recognize how both non-pharmacological treatments and pharmacological treatments have to be adapted for older adults, and particularly around the risks and side effects of medication. There, older adults have some unique vulnerabilities in that area. So our objective of these guidelines is to provide people with practical evidence-based guidelines on prevention, diagnosis, and management of anxiety disorders in older adults. And our main audience are health and social service providers to provide recommendations about how to approach and care for older adults with anxiety. We also, though, are developing education tools for older adults and family caregivers, and making recommendations that are important for policymakers to understand about access to treatments, for example. The process for this guideline was we did a whole series of systematic reviews on pharmacological and non-pharmacological interventions, asking questions about whether these interventions are effective or reduce symptoms of anxiety in older adults. And these guidelines would not have been possible without the hard work of a pan-Canadian group of experts from diverse disciplines. And I just want to take a moment to acknowledge our wonderful working group members and thank them for their contribution. I also want to acknowledge a number of other contributors to this work. We had some external experts weigh in. We had students. We had our wonderful CCSMH staff, in particular, Titus, Pat, and Sarah. And we had a lived experience advisory panel of 8 advisors across Canada who gave their perspectives of what it's like being an older adult and living with anxiety. So the guidelines I'm going to present are given a rating based on the certainty of the evidence that influenced them. And because this is seniors' mental health, there were some questions where there wasn't a large amount of evidence, but we were able to weigh the evidence and make recommendations that were either strong, which meant that most people would likely benefit from this intervention, or conditional, which meant that there may be some factors that you would want to consider before you recommended this intervention. Where we couldn't do a systematic review to answer our question, we reached a consensus in our working group on the recommendation and rated that based on the level of evidence that guided it. So an A would be a systematic review or meta-analysis level of evidence, and D is at the opposite end would be expert opinion guiding the recommendation. Okay, so let's get into the guidelines now, and starting with how we can better detect anxiety in older adults. Their first recommendation is that healthcare providers should be familiar with risk factors for anxiety in older adults. So first thing to know is that aging itself is not a risk factor for anxiety. The exception is fear of falling. Fear of falling does increase as we age, but other types of anxiety does not necessarily increase. And some people, they get less anxious as they get older, as they develop coping skills and emotional regulation, a change in perspective, wisdom. And the risk factors that we do know of, we do certainly know that women are more likely to have anxiety than men. Anything that may impact an older person's sense of vulnerability or their coping, things like disability, poor health, cognitive changes, those also contribute to anxiety. There's probably a sort of chicken and egg relationship between things like depression, insomnia, and anxiety. Those are all very closely related. And then there are also some protective factors to talk about. Life satisfaction, social connection as opposed to social isolation is very important. Having connections to things like your community, whether that is a religious community or your cultural community, are also important protective factors. Our next recommendation is that healthcare providers should familiarize themselves with tools to detect anxiety and consider using them in individuals who are at risk to be able to detect people who have anxiety. And we looked through a whole number of different anxiety tools. Ultimately, we found that the geriatric anxiety inventory had the strongest validity and accuracy for either generalized anxiety disorder or just detecting someone who has clinically significant anxiety symptoms. This is not an easily accessible tool, unfortunately, but in the guidelines, we do recommend some other tools that you might consider. The rating anxiety and dementia scale is specifically recommended when you are assessing anxiety in someone with cognitive impairment, where they may not be able to recall their symptoms and you have an informant who's helping you with the assessment. So once you've identified that someone might be struggling with anxiety, we move on to assessment. And the important thing to know here is that there are many causes of anxiety. Anxiety is this signal. It signals stress and threat. So we have to figure out what factors might be setting off this signal. To illustrate this, I'm going to tell you about Mrs. Bechter, who is an 80-year-old woman who has mild dementia. And she lives on her own in an apartment, and she's helped by her daughter, who visits a few times a week. She catches a cold and has a few symptoms. And then after a few days, she starts to have some difficulty sleeping. She gets up in the night and she's calling her daughter multiple times in the middle of the night, anxiously asking her when she's going to be coming for her visit. After a week of increasing anxiety and poor sleep, her daughter decides to take her to a walk-in clinic where she's prescribed a sleeping pill to help her with her anxiety and sleep. She sleeps a bit better the first night, but the second night, she's much worse. She's very confused, she's anxious, and she calls her daughter to say there's a stranger in the house. Her daughter rushes over and actually finds that her mother has fallen and she's cut herself. She takes her mother to the hospital, and the emergency physician completes an assessment and investigations and finds she has pneumonia. They prescribe some antibiotics and stop the new sleeping pill. And her daughter stays with her at the apartment over the next week, and her anxiety and confusion and sleep all improve. So that's an example of someone who has delirium which is misdiagnosed as sleeping and anxiety problems. And so thus the appropriate treatment is missed. And so the key message here is that when you identify an older adult with anxiety, the next step is a comprehensive assessment to understand what's contributing to this new or worsening anxiety. And as part of our guideline, we have prepared an algorithm to help with this assessment that reminds us in a way that anxiety disorder is really a diagnosis of exclusion. You have to rule out that there are any medical or other contributors before you can say that someone has an anxiety disorder. So you have to understand the person and their context, whether that be their medical history or psychiatric history, or any current psychosocial stressors that they're facing. And so when you delve into the anxiety history itself, you have to identify the nature of the symptoms. So is this panic type symptoms, or is it worry? And when did it start? How long have they been going on? How severe are they? Etc. And particularly when we talk about persistence and the duration of the symptom, that's important because a lot of the anxiety disorders, the exception being panic disorder, have the requirement that the anxiety has to have been going on for a little while. Like, they typically, the DSM defines it as longer than 6 months. So it's important to understand, is this something that has been going on a while, or has it started now? And if it's really new, what's this trigger? In terms of other mental health symptoms, one important thing to take from this guideline is that anxiety is often a presenting symptom of depression in older adults, the typical kind of anxious depression that we see. And so it's really important to have a high index of suspicion for depression if you're assessing an older adult with anxiety. Anxiety is also a risk factor for suicide, particularly in conjunction with depression. So all the more important to make sure that depression is one of the first things you rule in or out. Another recommendation is around assessment of medical conditions that may contribute to anxiety. There are many conditions that present with anxiety, like hyperthyroidism, or conditions that can that can be signaled by anxiety, like cognitive impairment or dementia. And certainly some medical conditions are associated with high rates of anxiety, things like COPD and Parkinson's disease. The guideline has recommendations around assessment and investigation of medical contributors. And this is a partial screenshot of a much bigger table that you'll find in the guideline that outlines the medical conditions that you might want to keep in mind. Older adults are also often on many different medications. And so it's important to establish if a change in anxiety is related in time to any medication changes, or if there may be issues with medication adherence. So poor adherence with a medication can also cause anxiety if it's, for example, if they're withdrawing repeatedly from medications or overdosing on medications. The guideline includes recommendations around taking a substance history and also provides this table of medications and substances that we know can contribute to anxiety. So to wrap up this section, let me tell you about Ms. Crocker. Betty is a 67-year-old woman who has been having issues with anxiety that she dates back like 15 years or so, probably since the menopause. And she has hypertension and atrial fibrillation, but they're appropriately treated. So she has dealt with this chronic issues of feeling jittery and having kind of racing ruminative thoughts during the day. And she often will have trouble falling asleep at night, and will sometimes wake up in the middle of the night with racing heart and a sense of impending doom. And the other thing she struggles with is her energy levels during the day. She often feels fatigued. And on the substance history, it comes out that to help her with these energy problems, she will usually go through at least one, sometimes two pots of coffee in a day, and maybe will have a Diet Coke with her dinner at night. On sleep history, she says that it is true that her friends won't share a room with her on vacation anymore because she snores and snorts loudly when she sleeps. And so a sleep study is done, and that reveals that she has actually quite severe obstructive sleep apnea, and she has nocturnal oxygen desaturations. And she started on CPAP therapy and advised to cut back on her caffeine intake. And 3 months later, she's had significant improvements in her anxiety and daytime energy levels. So we're going to move on now to treatment. So where there are situations where the anxiety may not be related to medical conditions, what's the next step in terms of addressing those symptoms? So our first treatment recommendation is that wherever possible, we prefer to start with non-pharmacological, like not medications, to treat anxiety, except in circumstances where there might be patient preference or severity of symptoms, and concern about risk. And for people who have clinically significant anxiety, but which hasn't quite reached the threshold of an anxiety disorder, we provide a recommendation for a stepped care approach to reduce anxiety the symptoms and prevent the development of anxiety disorders. So the first step is to recognize and address underlying causes. And we kind of talked about the medical ones already, but there also could be underlying psychosocial stressors. So if someone isn't able to meet their mortgage payments, for example, and that's causing them a lot of anxiety, addressing that stressor, helping to so connect them with some community supports, financial supports would be an important step. The next is to start putting into place some supportive and self-management strategies. And then if that doesn't work and the anxiety persists, we move on to higher intensity interventions such as psychotherapy and medications. In our step care recommendation, we talk about 4 self-management strategies, and those are bibliotherapy, relaxation therapy, things like diaphragmatic breathing or progressive muscular relaxation, mindfulness, and social prescription. So understanding anxiety, like learning about anxiety, is a really important part of overcoming it. And so reading, whether that's like a self-guided CBT workbook or another a book, it could be a more mindfulness-based book, that can be actually really powerful to help understand our patterns of thinking and behavior and how they may be causing us problems. Breath work and relaxation techniques actually have excellent science behind them. They help us to activate our parasympathetic nervous systems, and that helps to turn down the volume on our sympathetic response. And the science supporting mindfulness is growing, every year. And then social prescription is really about getting at the risk factor of social isolation and even supporting different kinds of behavioral activation. Getting people out and with people is a really important way to support people who are anxious. We also asked a question about exercise, and we found some evidence in older adults that exercise can reduce anxiety symptoms. And so combined with what we know about the benefits of exercise for anxiety more generally and the many upsides and very few downsides of exercise in older adults, we feel pretty comfortable recommending exercise as an important anxiety self-management strategy. But some people with anxiety get very stuck and they're not able necessarily to benefit or engage with self-management strategies. And at that stage, more intensive psychological interventions, like different psychotherapeutic interventions, can be explored. So let me tell you about Mrs. Sarah Lee, who's a 78-year-old widowed woman who lives in an apartment with her daughter. Her chronic health conditions are well managed, and her husband died about 2 years ago. And in the past year in particular, she's become increasingly worried and preoccupied about whether she's going to be able to continue to maintain her independence. She's really worried about losing her independence. And so she was actually so worried about it that she was initially reluctant to go and talk to the doctor about it, because she worried that if she told them how worried she was, that she would be told she couldn't live independently at home. So it took a while to get her to go and seek some help. She has been a worrier her whole life, and worries a lot about her family, the future, and often imagined worst case scenarios. She didn't think that it really got in the way through her life, but when you ask her family, they said that she was a real worried mama. It was a big part of her life, being worried about her family. But now her worries are there every day, and they're hard to control, and they get in the way of her sleep. And she feels tense with the worry, headaches, stiff upper back, restless, can't sit still for very long, always moving around the house in a kind of ineffectual way. Her mood has been more irritable. Isn't focusing as well she has trouble sticking with one task. And she stopped going out for her walks and going to her church. Um, she does she doesn't feel sad, She doesn't endure sad or hopelessness or suicidal thinking. Um, but you can see that there's a lot of overlap here between this and depression. And an anxiety score on the GAI 20 was 15, which is, quite clinically significant anxiety to the point where it would be almost considered diagnostic for GAD. And she was diagnosed with generalized anxiety disorder and connected with a counselor in the family practice who was going to do some CBT with her with a focus on targeting cognitive distortions associated with worrying, like her catastrophic thinking, and also a good amount of focus on behavioral activation, so re-engaging her with her social group and with exercise. So in our systematic review, we found that there was good evidence to support the use of CBT to treat anxiety disorders, primarily evidence for generalized anxiety disorder, but also for clinically important anxiety in older adults and other anxiety conditions. CBT, or cognitive behavioral therapy, if you're not familiar, is a short-term goal-oriented therapy that focuses on changing unhelpful patterns of thoughts and behaviors to help improve a person's feelings, solve problems, enhance their functioning. It teaches people perspectives and skills that can help stop that vicious anxiety cycle that we talked about earlier. Importantly, we found that there was actually evidence to support CBT across many different modalities. So that included group CBT, virtual CBT, brief versions of CBT. So not typically CBT is 8 to 12 sessions. So even shorter versions than that, shorter than 6. The studies were mostly in healthy, cognitively able older adults, but there were some studies in people with medical conditions associated with anxiety, like Parkinson's and lung disease, and people with some cognitive impairment, mild cognitive impairment. The literature does emphasize how it's important that these interventions be adapted to older adults. A lot of, sort of off-the-shelf CBT workbooks talk a lot about things like work and other kinds of role responsibilities, school, that may not be relevant to older adults anymore. So it is important that it be appropriately adapted for them and their circumstances. And some of the adaptations might mean a focus a bit more on behavioral strategies and a bit more on relaxation strategies and a bit less on the cognitive restructuring side of things. Or maybe you involve a care partner in the therapy, or you use repetition or reminders. Um, given this, that there's a need for adapting, we also make a recommendation that psychotherapy training programs deliver training in how to work with older adults. The second main psychotherapy recommendation is for mindfulness-based interventions. And there are a number of different structured psychotherapies that are centered on mindfulness, like mindfulness-based CBT or for mindfulness-based stress reduction. And so mindfulness is a practice where you cultivate a state of being that involves relaxed awareness, where you're focused on the present moment and you accept life as it is. And the science behind mindfulness is solid. Building mindfulness is of benefit to treat anxiety, and our work has confirmed that older adults are able to engage in and benefit from this intervention. The other thing that we are really acutely aware of is the issue of access to psychotherapy. And this varies a lot across Canada, even though there are now some provinces working towards better access to structured psychotherapies. Given that this is an effective and low-risk intervention for anxiety in older adults, we also provide recommendations to advocate for better access to these psychotherapies for older adults with anxiety. I want to come back to Mrs. Lee. So she has 8 weekly sessions of CBT, and she says there's like a bit of improvement in her anxiety symptoms. Her GAI 20 score has now gone from 15 to 10. But she continues to struggle with sleep and worry. She asks her primary care provider whether a pill might help, maybe a sleeping pill. He recognizes that she does have some ongoing symptoms of her anxiety, so it hasn't fully responded to treatment with CBD. And so it provides her with some education about how sleep interruption is a symptom of anxiety, and that the sleeping pill doesn't really treat the underlying anxiety disorder. And so she opts to begin a trial of sertraline, which is an antidepressant, And after 5 weeks with regular adherence to the medication, her sleep is better and her GAI-20 score has now gone down to 6. She continues to use the techniques that she learned from CBT. So when do you decide to consider a medication? When non-pharmacological interventions have been unhelpful and the anxiety is persistent and disabling, it might be time to discuss trying a medication. And so I'm going to highlight here just a few of the key medication recommendations we make in the guidelines. In our systematic review of pharmacotherapy, the evidence most strongly supports the use of antidepressants to treat anxiety, primarily GAD, but also panic. There were a few studies that also showed benefit for persistent anxiety that was subsyndromal, and a few that looked at anxiety in the context of medical illness. So antidepressants are generally well tolerated with a low risk of serious adverse events. They take time to work though. They take 4 to 6 weeks usually for the initial improvement and maybe 6 to 8 weeks for a more full benefit. So for someone who might be wanting a quick escape from their anxiety, they'll need a fair bit of support from the prescriber to stay the course. It's also important to be clear um, about the goal of the medication. I think we want to make sure people's expectations of what about medications do are not unreasonable. Like we can't get rid of anxiety completely. Nobody lives with zero anxiety, or they certainly don't live very safely. The idea is really to make the anxiety, to get it to a place where the person is able to cope and manage it. And that sometimes it helps to combine the medication with some psychoeducation or some simple CBT-based skills to help them build confidence in their ability to manage their anxiety. The next important medication recommendation is around the use of benzodiazepine. We found very little evidence to support that these are an effective and safe long-term treatment for anxiety. The longest study for benzodiazepines in anxiety in older adults was just 4 weeks long. And there's no doubt that a benzodiazepine, so this is a medications like lorazepam or diazepam, there's no doubt that these provide quick relief from anxiety. But if you think back to the anxiety cycle I presented earlier, a quick escape from anxiety actually provides a really powerful reinforcement for the anxiety. So you get, again, the short-term benefit, but it's quite detrimental in the long term. We also know from decades of observational research that there are quite a few harms associated with these medications, particularly in older adults. So there may be some use for benzodiazepines in the short term for very severe anxiety while you were waiting for an antidepressant to take effect. And the guideline does provide recommendations about how you would prescribe safely in that context to reduce the risk of someone developing a benzodiazepine use disorder. But we don't go into detail really around the issue of people who are already regularly using benzodiazepines for anxiety. The CCSMH has a separate guideline around benzodiazepine use that does talk about deprescribing and is a good resource for that. So the full recommendations around the medication management can be found in the guideline, and you can also find a drug summary reference sheet on our website. Well, the last thing I forgot to mention is how fortunate we are to have partnered with Jerry Medrisk. Jerry Medrisk is provided us with these really wonderful drug infographics and drug information sheets for every medication that we recommend that allows you to learn about how to prescribe and how to monitor those medications. And so the link to that is from our guideline, and I think probably we've dropped the link to that in our chat as well. I have one last case to tell you about. Mrs. Fields is an 86-year-old woman who lives alone in her apartment. And in a primary care appointment, she comes and tells her family doctor that she fell 2 months ago. She had stood up really quickly to go get to the telephone, and she felt dizzy and fell. And she was on the floor for several hours before the neighbors heard her and alerted the superintendent, who came up to open and help her up. She only had a few bruises and didn't go and seek any medical attention at the time. But since then, she's been, afraid to move around very much and has been canceling a lot of outside appointments and activities. She's also doing some things that are a bit maladaptive. She's taking the phone off the hook because she doesn't want it to ring and make her jump again. She's actually started reducing her water intake because she doesn't want to have to rush to the bathroom. And so the worry about the fact that she might fall again and not be able to get up is keeping her awake at night. So the GP, when they observe Mrs. Fields, they see that she has trouble getting herself up from the chair in the waiting room, and she has orthostatic hypotension. She's quite deconditioned, and she also has some vision problems, and she admits that she's lost her glasses. The GP goes and explores this fear with her, who's explained she's afraid of being alone and falling and not being able to get up. So the GP adopts the solution-focused approach and asks Mrs. Fields to think about some solutions that would make her less worried. And after listening, they reflect back that having a falls alert, arranging neighbors to check in, and learning ways to get up from a fall would be the most helpful things. But she's pretty clear that she doesn't want you to refer her to the falls prevention program because she doesn't think that she can get there. She won't be able to go. So the GP assists the patient to arrange a lifeline service, books an appointment with the optometrist. They work on a list of neighbors to check in, and then organizes a requisition for a home assessments by physiotherapy and occupational therapy. And a couple of months later, Mrs. Fields comes back for her follow-up appointment, and she's wearing glasses, and she has her falls alert alarm, and she has a four-wheeled walker that's been prescribed by the physio. She reports that now she's worked on transfers with the physio and has a transfer pole by the bed, and she has a raised toilet seat. And now she's feeling confident enough to accept a referral to the community-based falls prevention program that's delivered by the local public health agency, which includes balance training and also a CBT component. So fear of falling is a geriatric specific anxiety issue, and there are 3 recommendations that we make in the guidelines about fear of falling. The first is that we should remember to ask about fear of falling. It really should be part of our geriatric falls risk assessment. And then where the fear of falling is excessive or it's leading to some counterproductive avoidance behaviors, then we should really address it. In many cases, there is some basis in reality for the fear. And like in this case, there were some really clear modifiable risk factors that were contributing to her increase in falls risk. So we have to look at reducing the risk alongside reducing the fear. There are some very good evidence-based community programs that incorporate elements of CBT and exercise for falls prevention and fear of falling. And we do recommend that there's evidence for both of those things, exercise and CBT, and that we feel that these should be accessible to older adults in multiple settings. So coming to the end, the last thing I want to tell you about is that based on our guidelines, we have developed some resources and are working on more resources that can be used for education and to support conversations with older adults about anxiety. And you'll find those on our website. Something to look out for if you're a healthcare provider. We're coming out with some pocket cards and clinical tip sheets for healthcare providers to help you put these recommendations into practice. So if you are interested in finding out about these future resources as they become available, please do sign up to the CCSMH newsletter. So to summarize our guidelines in 5 points, the first is that we should ask about anxiety. The second is that we have to consider that there may be lots of different causes and contributing factors. The next is that we should provide psychological support. We should provide psychoeducation and options for self-management. The next point is CBT and mindfulness are 2 evidence-based interventions for older adults with anxiety, and that antidepressants are the first-line medication option when medications are indicated. So thank you all for coming. I think Titus is going to throw up our 2-minute survey for people to jump in and give us some feedback about whether you found this helpful. I hope that you did. While you're jumping onto that, oh, I can't actually change the slide while we're on that. So let me
That's
see if
okay.
let me try again. No, I can't. Okay. So we'll give you guys a minute to fill in the poll.
And I am seeing some Q&A questions trickling in here. If folks have any other questions that they'd like added, definitely feel free to pop it in the chat here and we'll try and get to them. Okay, we'll just give it another minute or so.
There's some, I'm scanning through the questions to see there's some great questions in here. Look forward to
Mhm.
answering them.
Yeah, I guess we can definitely get started. I'm seeing one here from a Janice here, wondering about the use of psychotherapy for anxiety in people with neurocognitive disorders. And is there a limit or score that we should consider on the MMSE or MoCA, for example? Great question.
Yeah, it's a very good question. I mean, one thing just to I want to like tell you guys about because it's very exciting. Is that we didn't have a big focus in our guideline about dementia and anxiety. And the reason is that very soon CCSMH is also doing a BPSD guideline for behavioral and psychological symptoms of dementia. And one of the priority areas addressed in that guideline is anxiety and dementia. So there's going to be a whole separate guideline that will address anxiety and dementia that will be coming out. So that being said, yes, so someone may have dementia or they may even have some degree of cognitive impairment. There's no screening tool, I think, that is that helpful in terms of ruling someone in or out for being able to engage in psychotherapy, because I guess that it really depends on where their deficits are and where their strengths are about whether they would be able to benefit or not. I think you would want them to be able to have some understanding of their symptoms, some ability to describe their symptoms, some ability to remember information from session to session, or remember with some cues and reminders. And so I think it's really on a case by case basis, evaluating whether somebody might benefit or not. The other thing to remember is that CBT is not one thing, right? It's a whole set of different skills and strategies and approaches. And so someone with cognitive impairment might not be the best to do cognitive restructuring, which is, a more abstract sort of process where you try to think about your thoughts. But they might be able very well to be able to do relaxation therapy or some of the behavioral interventions. And so you don't want to write someone off just because they can't do the cognitive therapy. The studies that looked at the individual components of CBT found that they're actually individually also quite effective. So they don't have to necessarily all be used.
Great, thank you. So the other few questions I'm seeing here are from the care partners and our attendees. And so some of them are chatting about getting that support from loved ones about, having those conversations about anxiety. And of course, with a lot of people having very, varying levels of understanding what anxiety is and what it might mean for their lives, how might someone initiate that conversation on anxiety, whether from the perspective of someone living with anxiety or supporting a family member with anxiety?
Yeah, that's a very good question, and something that we are working on is developing some tools and some fact sheets and information for people who support people with anxiety. So there's two perspectives of two parts to this question, I guess. So one is about if you're someone with anxiety, how do you communicate with your family members about your anxiety? And this is not always easy. You're right. People can sometimes be impatient with anxiety. Um, the truth is that anxiety makes us anxious. That they may see you anxious, and then that makes them anxious about whether they're going to be able to support you, about all kinds of different things. Depends obviously on the nature of your relationship, but and so I think it helps to be very explicit about what you're asking for, what you're hoping for from them in that moment when you're talking about your anxiety. Um, uh, I Now to take it from the perspective of the care partner, when you are, interacting with someone who is anxious, there's a few things that are really, really valuable. The first is to name it, I think. So somebody might be going on and on about their worries, being able to say, I can see you're really anxious. I can see that this is really troubling you. This is, and really naming what you're seeing. I think that can be sometimes be helpful. Providing that's a validating thing for people. I think validating to some extent the nature of, you're really anxious. It seems like you're anxious about this situation, and I can see why that situation might to some extent might be making you anxious. But I think the the key is to not necessarily getting into trying to reason with them or argue with them. The validation parts, I think, are really what people want to hear, that's more supportive. There's one tricky area, which is where if someone who's very anxious is coming to you a lot for reassurance, repeatedly, over and over again, and you're starting to feel quite burnt out from needing to provide reassurance over and over again. Reassurance is a bit funny. It's a bit like that escape, right? People are anxious, they seek reassurance, they feel a little bit better for a little while, short-term benefit, but still is stuck in the vicious anxiety cycle. So important for you to also get help, make sure that you have someone help support you on how to support them. And recognize that it's okay to also set limits on how much reassurance that you provide. I'm happy to talk to you now about this, but I'm not going to be able to, take your calls for the rest of today because I'm very busy. But let's spend some time now talking about these worries and how you're going to get through the day. That's I think, I think appropriate to set some limits around how much reassurance that you're okay with offering.
Great. And I think we have time for about one or two more questions. So there is a question here about treating an older adult who has been on benzodiazepines for decades, and how do you wean or change to a better option?
That's a really, really good question. So there are some, the first part is anytime you're thinking, considering deprescribing, it really has to be a collaborative process. Um, People become very attached to their medications, even though we know that that over time the effectiveness of benzodiazepines goes down. People develop tolerance to them over time. So even though they're taking the medication, it's probably not providing them as much benefit as it used to. And some of what is uncomfortable about stopping the medication is that people will sometimes have withdrawal symptoms in that process. And that can sometimes feel like it's the anxiety coming back. It's like the original anxiety coming back. And but that's not necessarily true. That could just be the experience of stopping the benzodiazepine means that you might temporarily have a little spike in your anxiety. So there's a lot of really great deprescribing guidelines. We link to some of them in our guideline. A lot of those guidelines were developed to help people come off of benzodiazepines who use them for sleep. So they're not, I think this is probably a gap and something that we can, think about that needs to be addressed is how do we give advice about stopping benzodiazepines when they're not being used for sleep, when they're really being used primarily for anxiety. But I think the same principles apply, that you provide information about why the benzodiazepines might not be serving them as well as they once did, that it may not be the appropriate treatment for them. And the potential risks and side effects and harms, which I think are all really important for people to make an informed choice about their medication. And the evidence is that when you provide older adults with information and reassurance that you are going to support them, you're not going to just stop them cold turkey. You're going to do it gradually. You're going to monitor their symptoms. You're going to, be there do this collaboratively with them. Then actually people are able to come off benzodiazepines. And there's all kinds of also interesting other strategies that we use sometimes. Putting medications, if you can have a compounding pharmacy, you can actually conceal the benzo so they don't actually know what the titration schedule is. So it's done blindly. That can sometimes be really helpful if there's really anxious about coming off the medications, then they don't know what dose they're on at any given time. So there are some different strategies. We don't go into it a lot in our guideline, but I'm interested that people are interested in this, and maybe it's something for us to know and work on as another tool.
And I think we have time for one last question here. There's been a few questions on accessing training for providers on CBT and how to incorporate that into their own practice. Is that something you might be able to speak to?
It's a really excellent question. So the guidelines, we're at the stage now where we are just launching them now. But I think that you're right. The next step is really about helping to pull together some resources that I think will accompany the guidelines. And so uh, I don't have no offhand right now where there are CBT training programs that are specific to older adults, but that should be a thing. Like if it doesn't exist, it should be a thing. So I think, thank you so much for bringing this up. We'll also take this back and think about how, as an organization, I think as CCSMH, we can help to share and promote information about training opportunities that are, because I think that it's that one of the things that really came through in our review, in our analysis, was that it was almost any sort of psychological support that was provided to an older adult with anxiety had benefit. It did improve anxiety symptoms, and so so learning some CBT skills that can be used at the bedside, used in your day-to-day interactions with your clients, I think are uh, really worthwhile developing. And so I think good suggestion that we start looking into how we can help sharing those opportunities.
Absolutely. And I see that Lisa here has provided in our Q&A some suggestions for CBT training resources.
That's great.
Excellent. Yeah. Okay, well, I think that concludes our webinar for today. So thank you so much to everyone for attending. We really appreciate your time, and we hope you found this event both informative and valuable to your own practice. We do have 2 more clinical guidelines that will be launching over February and March on the subjects of social isolation and dementia. So we're really excited for those. Be sure to sign up for our mailing list to stay tuned on the webinar events for those guidelines. Thank you again for attending today, and we hope you all have a great rest of the week.